Welcome back to my YouTube channel. If you are new to my channel, welcome to Medcode Insight. Hi, I am Nishava, a certified medical coder. In this video, we will discuss the level of evolution and management services based on medical decision making or time with coding practice for office visit. We will also cover the quick elimination method using scenarios based on different level of MDM, time, or scenarios that involves both MDM and time. Without further delay, let's get started. As we discussed earlier in the previous video about the two subcategories of the office visit of new and established patient, the subcategories are further classified into the level of evaluation and management services that are identified by specific codes. The basic format of the codes with the level of evaluation and management services based on MDM or the time is the same. Time is defined as total time on the date of the encounter. MDM is how the provider rates the degree of difficulty in establishing a patient diagnosis and treatment plan. In the evaluation and management code, the following structure is used. First, a unique number is listed. Second, the place or type of the service is specified. Third, the content of the service is defined. Fourth, time is specified. The following codes apply to the office or other outpatient service for a new patient. Code 99202 is for the office or other outpatient visit for the evaluation and management service of a new patient, which require a medically appropriate history and or examination and straightforward medical decision making. Code 99203 is with low level medical decision making. Code 99204 is with moderate level medical decision making, and Code 99205 is with high level medical decision making. When using total time on the date of the encounter for code selection, the total time is a single amount, which is the lowest number of the minute in the current range for each code. This time must be met or exceeded. For code 99202, 15 minutes must be met or exceeded. The time range should be 15 to 29 minutes. For code 99203, the time range is 30 to 44 minutes. For code 99204, with the time range 45 to 59 minutes. For the code 99205, with 60 minutes must be met or exceeded, the time range should be 60 to 74 minutes. For service lasting 75 minutes or longer, use the prolonged services code 99417. The following codes apply to the office or other outpatient services for an established patient. Code 99211 is for the office or other outpatient visit for the evaluation and management services of the established patient that may not require the presence of a physician or the qualified healthcare professional. The concept of the level of the MDM does not apply to the code 99211. Code 99212 is with straightforward MDM. Code 99213 with low level MDM. Code 99214 is with the moderate level MDM, and code 99215 is with high level MDM. For code 99212, with the total time on the date of the encounter for code selection is 10 minutes must be met or exceeded. The time range should be 10 to 19 minutes. The time range for the code 99213 should be 20 to 29 minutes. For code 99214, it should be 30 to 39 minutes, and for code 99215, it should be 40 to 54 minutes. For services lasting 55 minutes or longer, should use the prolonged services code 99417. Here are some coding guidelines we must follow when selecting the level based on the time. For coding purpose, time includes the total time on the date of the encounter. It includes both the face-to-face time with the patient and our family or caregiver or non face-to-face time personally spent by the physician or other qualified healthcare professional on the day of encounter. It includes the time in activity that require the physician or other qualified healthcare professional and does not include the time in activities normally performed by the clinical staff. In CPT 2024, time is represented by a single total time amount, which is the lowest number of the minute in the current range for each code. Each service that may be reported using the time for the code level selection has a required time threshold. The concept of attending a midpoint between levels does not apply. For office or other outpatient services, if the physician or other qualified healthcare professional time is spent in the supervision of clinical staff who perform the face to face services of the encounter, use code 99211. When prolonged time occurs, the appropriate prolonged services code may be reported. There are some coding guidelines we need to know before using the code 99211. This code is used for the office or other outpatient visit for the evaluation and management of an established patient that may not require the presence of a physician or other qualified healthcare professional. Coding guidelines include the patient must be established, the service must be performed in the physician office, the physician or non physician provider must have created the plan of care. These services must be in person face to face and are not billable for the telephonic calls. Presenting problems are usually minimals and typically 5 minutes are spent performing or supervising these services. Code 99211 can't be appended with modifier 25. Some examples of using code 99211 are office visit of an established patient for dressing change, office visit of an established patient for removal of uncomplicated facial sutures, office visit for weekly blood sugar check, which is drawn by the licensed practical nurse on staff, a regular office visit for blood pressure check, which was scheduled at the request of the physician. Prolonged services in the office or outpatient setting are represented by the add-on codes 99415 and 99416 for additional time spent by the clinical staff or 99417 for additional time spent by the provider. MDM or medical decision making includes establishing diagnosis, assessing the status of a condition, and or selecting a management option. There are four types of MDM: straightforward, low, moderate, and high. MDM is defined by three elements: the number and complexity of problems that are addressed during the encounter, the amount and complexity of data to be reviewed and analyzed, the risk of complication, and or morbidity or mortality of patient management. A problem is addressed or managed when it is evaluated or treated at the encounter by physician or other qualified healthcare professional reporting the service. It may be a minimal problem, self-limited or minor problem, undiagnosed new problem with uncertain prognosis, acute illness or injury, chronic illness, acute or chronic illness or injury that possesses a threat to life or bodily function. Let's understand through the table how the number of problems addressed affect the number of MDM. When there is one self-limited or minor problem, the level of problem address is straightforward. In case of two self-limited or minor problems, one acute uncomplicated, or there is one acute stable illness or injury, or in case of one stable chronic illness, the level of problem address is low. In case of two or more stable chronic illness, patient has one acute complicated injury, or there is one acute illness with systemic symptoms, or there is one undiagnosed new problem with uncertain prognosis, or there is one or more chronic illness with exacerbation, progression, or side effect of treatment, the level of problem address is moderate. In case of one or more chronic illness with severe exacerbation, progression, or side effects of treatment, or there is one acute or chronic illness or injury that poses a threat to life or bodily function, the level of problem address is high. Data to be reviewed and analyzed include medical records, tests, and or other information that must be obtained, ordered, reviewed, and analyzed for the encounter. Data are divided into three categories. Category 1 include review of prior external note, review or order of unique test, or independent historian. In the category 2, there is independent interpretation of the test. Category 3 include the discussion of management or test interpretation with external physician or qualified healthcare professional or appropriate source. Let's understand through the table how these categories affect the level of MDM. In the scenario where the physician or the qualified healthcare professional reporting the service review the minimal or no data, the level of data to be reviewed and analyzed is straightforward. In the scenario where the physician or the qualified healthcare professional reporting the service meet any combination of two items from 1 to 3 items or meet item 4 of independent historian of category 1, the level of the data to be reviewed and analyzed is low. To select the moderate level of the data to be reviewed and analyzed, the physician or other qualified healthcare professional reporting the service must meet the requirement of at least one out of three categories. From category 1, it must meet any combination of three items from 1 to 4. To select the high level of data to be reviewed and analyzed, the physician or other qualified healthcare professional reporting the service must meet the requirement of at least two out of three categories. From category 1, it must meet any combination of three items from 1 to 4. The risk of complication and or morbidity or mortality of a patient management includes decision related to further testing, treatment, and or hospitalization. For the purpose of MDM, level of risk is based on consequences of problems addressed at the encounter when appropriately treated. The assessment of the level of the risk is affected by the nature of the event under consideration. Risk may be minimal, low, moderate, or high. Let's understand through a table how minimal, low, moderate, or high risk affect the level of the service. At the straightforward level, there is a minimal risk. Examples include rest, goggles, elastic bandage, or superficial dressings. At the low level is example includes over-the-counter drugs, minor surgery with no identified risk factors, physical or occupational therapy. At the moderate risk level, the example include prescription drug management, decision recording minor surgery with identified patient or procedure risk factor, electromagic surgery without identified patients or procedure risk factor, or diagnosis or treatment significantly limited by the social determinants of health. At the high risk level, example include drug therapy requiring intensive monitoring for toxicity, decision recording elective major surgery with identified patient or procedure risk factor, emergency major surgery, hospitalization level care, parental control substances. It also includes decision not to resuscitate or de-escalate care due to poor prognosis. Here are some coding guidelines we need to know while selecting level based on MDM. MDM levels are not interchangeable among the different categories or subcategories of the service. The concept of the level of the MDM does not apply to 99,211 and 99,281. If a separate CPT code is reported for test interpretation or a management discussion, it is not counted towards the MDM when selecting the evolution and management service level. To qualify for a particular MDM level, 2 out of 3 elements must meet or exceed the criteria for that level. The final diagnosis alone does not determine complexity or risk. Multiple lower severity problems can aggregate to high risk due to interactions. Here is a coding guideline we need to aware when selecting a level of the service which is based on both MDM and time. Most evolution and management services are coded based on the level of history, exam, and MDM documented by the provider. But when the providers spend more time in counseling and coordinating a patient care than anything else, using time as a controlling factor will capture the level of the service more appropriately. Let's take an example of office or other outpatient visit for the evaluation and management of a new patient lasting for 45 minutes with low MDM. When we select the code based on the encounter with a duration of 45 minutes, it falls under the moderate level category, which corresponds to the code 99204. However, based on the given MDM, in this scenario which is low, the appropriate code would be 99203. The time component indicates a high level of MDM than the MDM mentioned in the scenario. You will typically prioritize coding based on the higher component, which in this case is the time. Therefore, you will report the evolution and management code based on the moderate level of the time component. What CPT code is reported for a patient comes into the doctor's office for her weekly blood sugar check. Her blood is drawn by the licensed practical nurse on staff. The visit takes about 10 minutes in total. Option A with the code 99202, option B with the code 99211, option C with the code 99212, and option D with the code 93792. In the given scenario, the patient visit is to her doctor office for her weekly blood sugar check. It means it is an established patient. First, we will eliminate option A with the code 99202, which is used for the new patient office visit. The patient comes in the doctor's office for the weekly blood sugar check, which is drawn by the licensed practical nurse. Means this service does not require the presence of the physician. We will also eliminate option C and D, as the service in both codes require the presence of the physician. Code 99211 is used for established planned care, may not require the presence of physician or the qualified healthcare professional. Since the patient is seen by a licensed practical nurse, the description of this code also gives us a hint that is that this code is for visit data, typically 5 minutes. So correct option is option B with the code 99211. Dr. Smith meets Mrs. John, a 50-year-old woman, for the follow-up visit about her ongoing management of hypertension and mild osteoarthritis. The encounter lasts for 30 minutes, during which the Dr. Smith discuss the patient's current medication, review her blood pressure reading, and provide guidance on lifestyle changes such as diet and exercise. After discussing the option, Dr. Smith decides to adjust her medication slightly, but no new complex tests are ordered, and the medical decision making is considered low. Option A with the code 99213, option B with the code 99203, option C with the code 99214, option D with the code 99204. In the given scenario, the patient visit is a follow-up office visit, meaning the patient is an established patient. First, we will eliminate option B and D with the code 99203 and 99204, both used for the new patient office visit. In the given scenario, the patient visit is a follow-up office visit, meaning the patient is an established patient. The encounter lasts for 30 minutes and the medical decision making is considered low. We have two options for selecting the level based on the MDM or time. We must use the option that represent the high level. Below is the table for an established patient. First, we will select the level based on MDM and then based on the time. When we select the level based on time, it represents a moderate level, which is a high level than the lower MDM level, which is considered in this scenario. Typically, you will prioritize the coding based on the higher component, which in this case is the time. Therefore, you would report an evolution and management code 99214 based on moderate level of the time component. Established patient office visit, chief complaint left tibial fracture, history of present illness. Patient is 13-year-old male, first saw on the last month. He was noted to have been injured when he jumped and fell while running down a hill. He sustained a physical fracture on the distal tibia. He is currently not weight bearing in a short leg cast. He has been compliant with his activity modification. Physical examination, he is intact to sensation. His capillary refill of the toes remains stable. There is no skin breakdown at the proximal or distal aspect of the cast. The cast is intact. Ancillary studies, radiographs order performed and built inner office of the left ankle show good alignment and positioning of the fracture. Growth plate is stable, impression left distal tibial fracture. Plan, he will continue with the use of his cast, maintain non-weight bearing status, return for reassessment with new X-ray in the 2 weeks. Cast care instructions are once again being reviewed, but evolution and management code is reported. Option A with the code 99204, option B with the code 99213, option C with the code 99214, option D with the code 99203. To determine the level of MDM in the given scenario of the established patient with the office visit having physical fracture of the distal tibia, where physical examination is performed and radiographs are ordered and reviewed, but no MDM and time is provided, we need to analyze the three key components of the MDM, which are problem address at the time of encounter, amount and complexity of the data to be reviewed and analyzed, and risk of complication and or morbidity or mortality of the patient management. First, we will eliminate option A and D with the code 99204 and 99203 used for new patient office visit. In the given scenario, the problem addressed at the encounter is the left tibial fracture, which is one acute uncomplicated injury, which falls in the low level. The data reviewed in the scenario is the examination of the cost and the physician order and read the radiograph. For the test, we are less than 2, we use the low level. In the given scenario, the risk is the low weight bearing cost care, which also falls under the low risk. As all three elements fall in the low level of the MDM table, our correct option is option B with the code 99213. A 15-year-old female patient with a history of cystic acne arrives at the dermatology oncology clinic, referred by her general dermatologist who is a part of same practice. The provider conducted a comprehensive history and examination and reviewed the patient charts, which included a comprehensive metabolic panel, renal panel, thyroid panel, and a skin biopsy. Final diagnostic statement is the chronic cystic acne. What are evaluation and management CPT codes reported? Option A with the code 99204, option B with the code 99213, option C with the code 99214, option D with the code 99203. In the given scenario, the patient arrives at the dermatology oncologist referred by general dermatologist. Both falls under the same group of same specialty but of different subspecialty. So patient is considered new to the dermatology oncologist. As this visit is the office visit of a new patient, we first eliminate option B and D with the code 99213 and 99214 used for established patient office visit. To find the level of the MDM, we need to analyze the three components of the MDM. In the given scenario, the problem addressed at the encounter is the chronic cystic acne, which is a stable chronic illness and falls under the low level. In the given scenario, the data reviewed is the patient chart, including comprehensive metabolic, renal, and thyroid panel, and a skin biopsy, which falls under the motor table because more than three data were reviewed. The risk for the chronic cystic acne is the minimal risk, which falls under the straightforward level. Let's mark all these elements on the MDM table given on CPT page number 10 to find the correct level. In the given scenario, the three elements of the MDM falls in the different levels. To find the correct level, first we have to remove the lowest level, which is the straightforward. After removing the lowest level, we have to choose the lower level as a correct level, which in this case is the low level MDM. So our correct option is option D with the code 99203. Thank you for watching. If you have any question or need further clarification, please feel free to write in the comment section. For more detailed guidelines, CPC mock exam related questions and notes, email me at the giving email ID.